Hello, my name is Goran Stankovic. I'm interventional cardiologist from Belgrade, Serbia. And first of all, I would like to thank course directors for the kind invitation to participate in 11th Bulgarian bifurcation and complex coronary intervention course. I'm sorry that I cannot be live with you in person in Sofia, but I look forward and I hope that next year we will be again in position to meet each other and directly participate in the meeting. The title of my talk is Update of Coronary Bifurcation 2023, and I will share the perspective from the discussions of the European Bifurcation Club in the consensus documents that we published in the last couple of years, especially this year consensus document focused on pitfalls of bifurcation PCI. As introduction, I would like to say that many trials from the very beginning of drug-eluting stents have compared the benefit of provisional versus two-stent strategy for coronary bifurcations like the Nordic, BBC1, BBK, Cactus, and none of them showed the benefit of systematic two-stent strategies. Even in EBC2 study, in patients with larger true bifurcations, there was no benefit of culotte compared to provisional. However, the longer the follow-up, the longer we follow the patients, like in this individual patient meta-analysis from Nordic 1 and BBC 1, after 2 years of follow-up, the curves of mortality started diverging, showing higher all-cause mortality with two-stent strategy compared with single-stent. And at 4 to 5 years of follow-up, there was clinically significant difference in mortality in patients treated with complex strategy. The most recent publication from the last year from Patrick Serruius is a 10-year all-cause mortality from the Syntax trial, Syntax Extend, and they evaluated the impact of coronary bifurcations as well as on the stenting technique in patients with left main and multivessel disease. And the findings were surprising for us. First, for percutaneous treatment, presence of bifurcation compared to no bifurcation increased 10-year mortality rates, and similar to all prior registry data, at 10 years of follow-up, mortality rate was higher with complex two-stent strategy compared to single-stent strategy. So based on all this evidence, European Bifurcation Club ethos for treatment of bifurcations are to try to keep procedures simple and safe, try to limit the number of stents that we use, but key is to respect the original fractal bifurcation anatomy and using tubular stent with optimization techniques to try to reproduce fractal anatomy. Our aim is to have well-opposed, well-expanded stents with limited overlap. So for the European Bifurcation Club, provisional side branch stenting strategy is the gold standard approach for the vast majority of bifurcations, including the left main. However, it's very important to understand that provisional stenting is a treatment philosophy. It does not mean single stent technique. Actually, for us, provisional stenting is approach of bifurcation PCI in a stepwise complexity increasing manner. So we add layers of complexity when it's necessary, but we stop at every stage of procedure in which we achieve good result in both branches. And of course, we respect the need for having, in some cases, two-stent strategy to achieve optimal procedural result. And from the EBC consensus document, there is also clear definition for use of elective planned two-stent strategy for patients with long side branch lesions, high risk of side branch compromise, or difficult side branch access. But for us, when we plan two-stent strategy upfront, this should be done in a provisional stepwise approach, finalizing procedure using T-TAP or culotte strategy as a part of provisional. So T-TAP and culotte are not bailout procedures, are not the failure of provisional. It's just the last fifth step of provisional strategy. But of course, we accept the available evidence from randomized trials, and for operators with the appropriate experience, double kissing crush is a valuable option also for complex left main bifurcation lesions included in the DK Crush 5 trials. And this is a MEDS classification of the European Bifurcation Club, updated recently by Yves Louvar and Francesco Burzotta, and there are 4 different stenting categories, but nowadays we mainly use provisional or A strategy, main vessel stenting across the side branch, or the S strategy. S strategy is precise ostial side branch stenting, and then, like in DK Crush, stenting after that the main vessel. So the difference between these two strategies is that in provisional or inverted provisional, we start our stenting from the proximal main vessel, and we go with stent either in distal main vessel or inverted technique into the side branch, and that technique may, but it's not necessary, finished with second stent. However, in S strategy, when we stent precisely only the ostium of the side branch, and then we are mandatory to put the second stent in the main vessel, in S strategy, we always finish procedure with 2 stents. This is the algorithm of the EBC based on the expected risk of losing the side branch. So for true bifurcations with extensive atherosclerotic disease of both main vessel and clinically relevant important side branch, if we expect low risk of losing the side branch, we go standard provisional crossover from the main vessel into the distal part of the main vessel, and then we put second stent with T-stenting, TAP stenting, or culotte, depending how much we pull back stent from the side branch inside the main vessel. And this is a case example with courtesy of Thierry Lefebvre and the team from Massy. Senior patient, accelerated angina. Of course, anatomy directly informs us about the complexity of anatomical complexity of disease, but in addition to many questions related to procedural planning, one of the key questions is which technique and whether we should use 1 or 2 stents. And for us, angiography is for Bifurcation Club our GPS system. Based on the anatomy, we try to understand plug distribution, and we try to evaluate the risk of losing the side branch. So this is in our perspective lumen contour, and this is vessel contour with plaque in the distal left main, which is almost completely in front of the ostium of the LAD. So if we go to our algorithm, is diffuse disease of both branches, but we believe that crossover stenting has low risk of circumflex occlusion. So our strategy will be in this case provisional crossover stenting, finishing with second stent as a T-stenting or maybe TAP if second stent is necessary. And this is the procedure, the first stent and then T-stenting in the circ and optimal final result. However, if based on the anatomy, we expect major risk of losing the side branch after main branch stenting, there are 2 different treatment strategies. One, for experienced operators with DK Crush. DK Crush is a good option, and this is typical case, diffuse disease, very tight disease in both LAD as well as in the circ, and we go again to our algorithm, major risk of losing either branch after stenting. So operator, in this case Shaoliang Chen, decided to do DK Crush, and this is the final optimal angiographic result of DK Crush procedure. But there is another option for this kind of major concern. We can go to inverted provisional, which means stenting from the main vessel into the side branch, then optimization of the result, and then second stent can be implanted as inverted culotte and inverted T or inverted TAP. And this is a case example 111, isolated distal left main lesion, but with large plaque burden and high risk of losing the side branch in any direction that we are placing the stent. So the operator decided to do inverted provisional, stenting the more complex lesion, in this case circ, because of the angulation and possibility to put second stent in a more straightforward, and to use inverted tap as a plan upfront to stent strategy. And you see stent deployed and optimized in the circ, and then positioning and final result of the tap stenting for distal left main. Two important key messages, in addition to understanding the anatomy plaque distribution. Procedural guidance by imaging significantly reduces the event rate, and in this case, this is very important publication from British Cardiovascular Intervention Society, which tells us that use of imaging reduces both early and long-term mortality. So image guidance for EBC is strongly recommended, especially for complex bifurcations, and almost mandatory for every left main PCI. And the last year we published together with Korean and Japanese bifurcation clubs consensus statement on physiological approach, which I strongly recommend to all attendees of your course. And we discussed precisely indications for use of physiology in coronary bifurcations. And to finish this presentation, I will focus on pitfalls, technical troubleshooting and prevention, the latest 16th consensus document from EBC. In this document, we not only describe the technique, but we go to potential pitfalls that you may face, and then we describe how to troubleshoot those pitfalls. For example, this is no pot, or pot balloon is too small. You see that if we don't adequately oppose and expand stent in the proximal main vessel, we can have either abdominal rewiring, or we can have problems in passing new devices, in this case, balloon inside the stent. So pot is the key, and abdominal rewiring results in stent deformation, and here with the courtesy of Niels Holm, you can see partially crushed stent. And this is again case example of Dr. Lefebvre, complex anatomy, distal left main, lot of calcium, diffuse disease. So inverted provisional was again because of angulation and plaque distribution, the strategy. This is crossover stenting, left main circ, direct stenting, and then after that, kissing balloon inflation, however, without pot. And the final angiographic result is optimal. And I'm sure that most of the people in the audience will gladly accept this final result of left main PCI. However, operators decided to do pullback from the circ to evaluate stent expansion. Distally, very good result, but when we come proximal into the left main, what we see is this. IVUS control showing left main stent compression because of abdominal rewiring since the pot was not done. In this consensus document, we describe how to troubleshoot. So this is the case of abdominal wiring. Our recommendation is to use dual lumen catheter and then over the wire lumen to wire through the lumen of the stent. And here we have confirmation by OCT that wire initially outside. After rewiring, both wires are inside the stent and the result is optimized. And these are very nice images by Remo Albiero showing that if you have abdominal wiring for ostial left main stenting, one possibility to face is troubleshooting and difficulty to go with balloon or IVUS catheter which stacks at the proximal edge. So to correct this, we again recommend to use wire inside the stent, dual lumen catheter. Through that dual lumen catheter, rewire centrally through the stent, and then of course repeat proximal optimization to avoid abdominal wiring. And Eve has shared kindly these mechanisms of longitudinal left main stent deformation which I think are clinically very relevant, occur according to Excel study in IBUS evaluation by 6.8%. So every 15th patient has mechanical longitudinal deformation of the ostial stent in the left main, and actually accidental intubation of the guiding catheter during pullback of devices or during removal or of partially deflated balloons can create deep sucking and longitudinal deformation, which increases adverse clinical outcomes. In this document, we also discuss for each two-stent strategy the pitfalls. This is just example of sequential crush that we recommend, because if we use balloon to crush, which is distal main vessel reference, because of the fractal geometry, you can see that with 3.5 in this left main, we cannot completely crush the stent. We have to use like pot 4.0 or even 4.5 to completely crush and make safe procedure. Also for culotte, we discuss again with this nice illustration by Remo Albiero, possibility that when we try to cross distal cell, sometimes we really go abluminal again, distally close to carina, and going with balloon, what we do, we actually create a gap and partially crush the stent. Or if we recross into the side branch too proximal, then we create this metallic neocarina. And here visible heart lab shows you how metallic neocarina can create really new metallic carina. Here yellow arrow points to that one. And this is the reason to focus and to try to cross really distal cell. So, dear colleagues, I would like to conclude that according to EBC in 2023, we believe that stenting technique in complex bifurcations should depend on individual patient's anatomy, but also on operator skill and experience. Stepwise provisional for us is a logical, straightforward, reproducible, and versatile strategy, and remains the treatment of choice for vast majority of bifurcations, including left main. Elective two-stent strategies may be considered for important side branch with complex and extensive disease according to definition 2 study criteria, for difficult side branch access or high risk of compromise, and use of imaging and physiology is strongly encouraged to decide the appropriate stenting strategy and optimize the result of bifurcation PCI. I thank you very much again for your attention, and I wish you successful meeting.
So, Goran was amazing as always. Unfortunately, we don't have a direct connection with him at the moment. And probably a few words for discussion, or if can give his lecture, and then we can make a little bit longer discussion. And I'm sure that there will be questions and comments for sure.
So, may I have my my slides? Can you come back to the first slide? First slide, please. Okay. So, I don't know who decided to ask me this presentation, because you can see that this is, I was really surprised. Personal perspective on bifurcation treatment. So the recommendations reflected by personal experience and feeling. So I think feeling is important when you are an interventional cardiologist facing a lot of different situations. But coronary bifurcations, stenosis were treated in the 80s with kissing balloons. At that time, 2 times 9 French guiding catheters without stents. Before EBC in Massy from 95, we were interested by coronary bifurcation lesion treatment as a challenge, and especially for left main refused by surgeon, too old. With the first stents, PS 153, I don't know if someone used this stent in this room. Many operators used empirical technique to treat them with poor published results. So at that time was the time period of feeling, you know. I feel this is good, so yeah, do it. But I had the sentence, following my long experience, I can tell you, blah, 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 blah. What I like is data. After 1 or 2 EBC meetings in Bordeaux and then in Roma, where all these techniques were presented, we moved quickly to data collection and production in EBC. In 1996, with Thierry Lefebvre, you have seen his case, how good he is, and we used this bench from science faculty in Paris, and we deployed stent after the program in the cath lab with my own camera. And we discovered, and we were very happy to discover that when we enter towards the side branch with a wire and a balloon, you are projecting metal in the side branch, and you are creating, on the opposite side, distortion. And the distortion can be corrected with a kissing, and then you have a very good position to implant a second stent without too much overlapping. Thierry was calling that you can stent 2 vessels with a single stent, which is a bit exaggerated, I think. But very quickly, so we were very happy with our bench, but we discovered, I think it was the 3rd year of Bifurcation Club, I invited a physiologist, engineer from California, Ghassan Kassab, and he presented scaling laws of vascular trees, of form and function. Of form, I discovered, probably others probably knew this anatomy, that coronary tree and also trees in nature are a pseudo-fractal objects. They have self-repetition of modulus, and the modulus here is a bifurcation. And the bifurcation is not a big tube and a small tube. This is 3 diameters, following the rule of Murray, or simplified in finesse formula, the one we use in the cath lab, and even the other one, Uoka formula. What is important to understand is that the size at any place in this tree, the diameter of the vessel, the length distal to the measurement, and the flow are proportional to the amount of supported myocardium. So this anatomy is a physiology anatomy. This is the base of the distribution of blood in the tree. And this is, nature is not always perfect. This is its function. The function of this is to distribute the blood. But at the level of any bifurcation, you have not straightforward high velocity flow, but some disturbances. And the disturbances are opposite to the carena. On the carena, there is high velocity flow, which generate a high wall shear stress, which is anti-heterogenic. Opposite to the carena, you have recirculating flow, generating a low wall shear stress, which is pro-heterogenic. Explaining the picture you see at the bottom left by Renu Virmani, showing the development of atheroma opposite to the carena, with the carena free of atheroma. When you treat this lesion, you want to treat perfectly with the 3 diameters and 2 stents, 2 vessels on the top right. Then you are again the same flow in this bifurcation. And this is generated, again, René Virmani, bottom right, this is generating a neo-intimal hyperplasia on the wall opposite to the carena. And this is the place where occur neoateroma and then neoatherosclerosis. On the contrary, the metal on the carena is submitted to high velocity flow, and this is responsible of late or no endothelization. You see this, work coming from Bonkonku. It's a very rustic simulation. And you can see at the top left, A is the normal anatomy, normal. This is a simulated anatomy of a coronary bifurcation. And you see that this limited amount surface of low wall shear stress. It was described in the slide before. When you change the diameters, you have here several kinds of change in diameters. For example, only 2 diameters, a single diameter for the main vessel and a small tube. And you can see that you are generating a lot more place for low wall shear stress. So we can, and this is not demonstrated, this is has to be confirmed by more study. We can suppose that this will be the reason for neoateroma development in the future. So Goran presented this 4 principles I proposed a few years ago. So this was restore and respect functional anatomy, and that I think this is, for me, this is very important. Bonkonku developed the concept of relevance of side branch, clinical relevance of side branch. He was studying bifurcation between LED and diagonals. And he remarked that revascularization for clinically insignificant side branches cannot be translated into clinical benefit and may even be harmful. It means that some branches has to be protected, not to be occluded and create MI, which is an endpoint, but they don't have to, you don't have to think systematically to treat with balloon or even stent, except in case of bailout. He tried to use, to define what is a relevant side branch. He used this work by Yashamovich, saying in 2003 that when a vessel, a stenosis, is in a vessel supporting that more than 10% of myocardium, then the treatment, the revascularization, not medical treatment, revascularization, may have an impact on mortality at 10 years. He adapted that to the diagonal branch. He tried to find how to, in a bifurcation, how to measure what is the amount of myocardium supported by the diagonal. And of course, this is not possible with MRI, could be possible in the future with CT scan with perfusion. But what he did, he used a surrogate of the ischemia, which is a fractional myocardial mass, how to recognize that a side branch is supporting 10% of myocardium. And he published, a colleague of him published this, showing that when you are facing a bifurcation in the left main, the circumflex is a vast majority, enormous majority of cases is relevant, more than 10%. For non-left main bifurcation, pointer. Oh, okay, sorry for this. The non-left main bifurcation, only 20% of them are clinically relevant with supporting more than 10% of myocardium. And supported myocardium is much bigger than ischemia. So you have to remember that these branches probably have not to be treated. So relevant side branch, he made some score, and he found also that the diameter is not a good way to define the vessel, which is supporting 10%. He found that a vessel that is more than 73 millimeters is defining a vessel supporting more than 10%. So on the left side, I don't know why it's not working again. So on the left side, oh, okay. Okay, so on the left side, you have a single proximal diagonal. This is relevant. And on the contrary, on the two on the right side, you have several diagonals. None are significant. So this is the second principle, simple protection for non-relevant side branch. You protect because if you lose the side branch, sometimes you may see an ST elevation and you will have to reopen the vessel with a balloon and why not with a stent if necessary. This is a quite old meta-analysis comparing a single versus double stenting. And you can see that for overall mortality, there is no difference. For TVR, there is no difference. But for MACE and especially driven by target vessel revascularization, target lesion revascularization, this is a recent meta-analysis, more than 8,000 patients with left main bifurcation. It is found again that it's better to do a single stenting than to do a double stenting, of course, if it's possible. So this is the third principle, which is limit the stent number. I think we have enough information to say that this is really very important. And the last one is about stent thrombosis, and this is again the stem meta-analysis showing that when you are a double stenting, you have more DES thrombosis and more myocardial infarction. So another point, since a long time work by Waxman, the Desert trial was showing that overlapping stent was also a big factor of stent thrombosis. And this has been simulated, the risk of stent thrombosis, showing in this study that when you have a thick strut, you are creating turbulence phenomenon, which are responsible of more platelet activation and thrombus. In another simulation here, on the right, you see the position of the stent. In the case 1, this is embedded. In the case 2, this is apposed. And for 3 to 7, this is malapposed. The most severe malapposition being at the bottom. And you can see that when you are a moderate malapposition, you have a development of stent outside the stent and slightly distally. And when you have very severe malapposition, you have a risk of stent thrombosis, which is mainly just distal to the stent. So this is important to consider that we need a single stent layer, no overlap. We need a well-deployed and a well-apposed stent. And as said Goran, the best way to know if it's done is to perform intravascular imaging. So my perspective and the technique I was using since the beginning of DES, I never did another technique than a strategy for any bifurcation lesion. So this is just to tell you that this is feasible. So after that, they asked me to give my feeling. So is there a place for feeling? I think yes. You have the principles and you have the feeling looking at the anatomy of the patient. So I will present some unusual cases. The first one is an unstable patient with a bifurcation between LAD and first diagonal. This first diagonal is clinically relevant. This is a single one, big. So this is lesion 1, which is 111 or 101. What to do? We can do a decay crush, tend the side branch, and put a crossover stent after that. Or you can do that. You take a stent from the diameter of the diagonal. You deploy. of course, immediately you give a second diameter, which is the diameter of the proximal LED, and you exchange the wires, and you do a kiss. And you got this result. And if you look cautiously, you can see very clearly that with the kiss, we projected metal from the diagonal to the lateral wall of LED. So it's nearly a perfect reconstruction of the bifurcation. And at 3 years with a CT scan, the result is still perfect without neointimal proliferation, visible one. A second example, unusual, no, not unusual, with the so-called very complex, the one that is for decay crush in many places in worlds and many centers. This is a complex lesion of LED diagonal with a long lesion in diagonal, again a single diagonal relevant, and also some concern about the distal left main. So you put I put 2 wires, I pre-dilated with a balloon with the diameter of the distal vessel, then I implanted a stent crossover from LED to crossover from LED proximal to diagonal to distal. And after that, on the right, we see the result on the diagonal. So using the diameter of distal vessel, you are not occluding the side branch. This is really rare. So after that, you have to do a pot. This is the pot. Again, this is the result. If the pot is well done, you are not closing the side branch. If the marker of the balloon to perform the pot is more distal to the tip of the carena, then there is a risk of occlusion. So now we are facing this simple lesion in the diagonal, which is relevant, so has to be treated, and was prepared with a balloon. This is exchange of wire on the left. Will take a bit of time. Sorry, just a few seconds to see. So the maneuver is a pullback of the pre-shaped wire from the LED to enter the diagonal. So you rotate towards the side branch and you pull very slowly. And after some patience, you will see the wire jumping in the branch. So I think this is an important technique. This is the way to enter the most distal cell. After that, you remove the diagonal wire, taking care of not jumping with the guiding in the vessel. And you have 2 free wires, and you perform the pre-dilation of the side branch. And you see the result on the left. So regarding this result, we may discuss if it's necessary to do more. But this is not a small diagonal that you just treated not to avoid the occlusion. This is a vessel that if a restenosis occurred, will have a clinical translation. So this is why I decided to put a long stent in the diagonal. So treated long lesion with a stent is not only for decay crush. This is possible with a provisional. So which technique? T and tap. T and tap are the same technique. When you look at the left with stent enhancement, we see that we have projection of metal from the main vessel to the side branch. We will perform a T stenting. On the contrary, on the right, we did a re-entry towards the side branch from proximal, so we projected metal in the middle of the main vessel, so you have to do a tap. So T-tap is the same. So after T-stenting, I did the kissing, which is mandatory. Kissing is mandatory after double stenting, any technique. And just to show you, no, sorry. I don't know what's the problem, yeah. Just to show you the result, that's the minimum. Okay, so you can see the result on the right, which is for me very acceptable. Another example, maybe more unusual, is this one. You have, in fact, 2 bifurcations, LED diagonal first and diagonal bifurcation. Again, this is a relevant branch. So to be creative, remember, limit the number of stents and try to avoid overlap. So my decision here was to prepare towards the diagonal branch after 3 wirings and to stent from LED to the most distal part of the first diagonal. Of course, the diameter is chosen from the diagonal. And this has to be completed before the kissing here. I just saw on the distal diagonal probably a dissection. So I added a stent, trying to limit the overlap, or avoid the overlap. And after that, I did the kiss. I did post-treated the access to the side branch in order to put another stent in the other branch of the diagonal. So this is, after that I did the pot. After that I implanted the stent in the second branch of the diagonal. Destenting, avoiding overlap. And now we are back to LED. After wire exchange, of course, I implanted another stent in the LED. Kissing, and the final result. So why I did this multiple stenting from proximal to distal, this is the only way to limit the overlap. If you go from distal to proximal, then you will have overlap. This case is something a bit different. It's more knowledge and feeling. What you are facing on the left is a single coronary artery. So if you look at the beginning of the right coronary artery, you are maybe I can. No, see here? No. Yeah. Here you have the LED taking off from the proximal part of the right. And this vessel, the posterolateral here, is continuing with the marginal, with the circumflex territory. So you have to understand that the posterolateral branch is distal main of the bifurcation and supporting a big amount of myocardium with the other branch, the PDA. So this is a matter, you have to evaluate the risk here. Fortunately, the anatomy of the lesion itself is not so difficult and was wired very easily. Was pre-dilated, was stented from distal right to posterolateral, and you can see that the PDA is still patent. A pot was performed, then a kiss was performed, and you can see that now the result is good on the distal bifurcation. I have to treat the second segment lesion in the right, and this is the result. Just more feeling. So that's a question for you. Maybe in the room, people will help me to explain what I will show you. Recently has been described the cell closure, was especially with biodegradable stent, was observed the closure of a cell in front of the side branch when the strut were not removed. But it has been also described with a metallic stent. And my feeling is that this is related to non-respect of the three diameters. You have two on the right side. You have two diameters, a big tube and a small tube. It changes completely the flow, and this is provoking stagnation in front of struts and closing the cells. And on the contrary of what you see to the right. So how to confirm this? I need access to databases with crossover stenting without removal of strut in front of the side branch. That were expertised with OCT and at follow-up, measurement of the diameters, confirming that the reason is a single diameter from proximal vessel and distal vessel. I can find that maybe in IVES databases. I'm looking to Akiko. And another thing that I have observed rarely, but is this. When you are stenting from LED to circumflex in a very big a big angulation between left main and circumflex, which is related normally to a long left main. When you have a long left main, you have a big angle. You stand from proximal, from left main to the circumflex, and you can observe this, which is on the external part of the stent. The elongation is not enough to follow the wall. And you have this kind of design. And after that, it's very difficult to crossing to LED to do a kiss, very difficult to get a good result because the metal cannot be opposed. So what will be very interesting is to use either a simulation or a bench to test the limitation of the actual stent to help the choice for the treatment. So we are at the end. I think data is very important, but to begin the research, you need an idea, and it's coming normally from your intuition. So intuition is important. This is a sentence from a French writer, painter, and filmmaker. Science only serves to verify the findings of instinct. Thank you very much.
So, thank you, Yves. It was quite an interesting presentation.
Was not easy, huh?
Yeah. It was not easy, but I think that the personal perspective and more or less, I think that an operator with, let's say, more than 10,000 or even, I don't know, how many PCIs you perform? 20,000?
A bit more.
A bit more.
Allez,
this is a little bit more than...
Let's say 30,000, I think the maximum.
This is a little bit more than any randomized interventional trial, patient included in any interventional trial. So the personal experience and personal perspective should be respected and should be taken into account. So the discussion is open. Some questions, comments. We have some maybe 5 or 6 minutes for...
Dobrin, may I start?
Yes.
You know, it was stated by Goran Stankovic today that EBC approach to bifurcations is much more philosophical than procedural. I would like to translate a little bit this message, and this is the truth, because if we limit already gathered data into the rules, I can say we know almost everything. But still we believe there is no two the same bifurcations. Then the bifurcation can be solved, the problem of bifurcation can be solved by many approaches, and everything depends on emotions. So I believe that these positive emotions, guided by the experience, by the devices which you need to have on your shelves, then you can really be happy treating the people with a success. Do you agree with me?
I will say guided by data. Data, you know, limit. Yeah, but data. Where I agree with you is data is from population of very diverse patients, and I've shown at least one that is something we don't have every day. So I am guided by data, but after that, I think it's very important for when you are facing complex cases. And at the beginning, for young operators, the bifurcation can be complex. It's very important to take time to analyze the different possibilities. And not to emotion, the kind of emotion I don't like is that, oh, this is complex, I have to do a decay crash. That's not a good emotion.
This is no emotion.
That's not a good emotion.
No, that is not. The challenge is not to use decay crash as a European.
No. We can use, I never did, but decay crush can be done, but you have to remember that decay crush is more complex to perform than provisional, except culotte, which is provisional. So I think data are important. I mean, the rules, the 4 rules are important. So it's important to have these rules in your mind to design a specific strategy for the patient you are treating. And here is the place of feeling, of experience. I have seen this situation in several times, so it was working with this technique, not with another one. This is exactly the discussion you need before the procedure, alone or with your colleagues, which is even better.
Definitely, I agree with you, but there is also, that was also stated by you that you hate this sentence, according to my experience.
Yeah.
But on the other hand, we have to take this experience from our, let's say, proctors, masters, because, you know, you can accelerate, you can shorten the way of learning. So sometimes it's not easy to stand these announcements. Oh, yeah, this is something normal. I am sick of this kind of bifurcations. But according to my experience, I would propose to do like that. It can be not easy, but I believe that data was accumulated by the experience of the people.
Yeah, but people are following my experience. I have heard that, you know, several times. And if you raise your hand, you ask, do you have data? They said no. They have data here, but they don't have data published.
Just a short comment regarding that. Actually, you cannot underestimate the importance of experience.
Yeah.
Because if it based on experience, the operators are performing PCI.
Yeah.
They perform their PCI and they perform in real-world interventions, not based on the guidelines, but based on their abilities. And sometimes I say that the biggest problems for the interventional cardiology in general, not only for big bifurcations, comes from the point that we are doing what we can, not what we should do. Because if the regular operator is doing 1 left main stenting per month, and then you collect a registry, and you will have quite a diverse population of operators, of experience, and then experience influences the data. And this is the influence of the experience on the data. And just to finish, you know, this is a good old wisdom that the good decision comes from experience and the experience comes from bad decision.
This is also the truth.
Just about, no, you are neglecting something. Is that in the long history already of PCI, the material, the devices, the evolution was fantastic. What was very bad, impossible in the 90s, we were doing with Thierry Lefebvre many culottes. And after that, we went to AHA meeting to show how to treat with rotablation the 35% of stenosis. You know, so at this time, culotte was impossible. So after that, with a synstrut and drug on the stent, culotte become again something that you can perform. So the experience, this is not your experience. This is many different experience corresponding to different time periods where such new material were available. That's a mix of So there is a place for experience, a feeling. When you are in front of your coronary angiography, this is important. But follow the rules is also very important. Create the rules and follow the rules.
So, thank you for this philosophical discussion at the end of the bifurcation session.